Okay, here we go, part 3. This is just some basic stuff on transfers, what we'll be doing in the lab. This week we'll be doing the sit to stand and the stand pivot transfers, almost some core stuff. Okay, so just some basics around positioning. See how she's got her hand palm side up as she hangs onto the gait belt. She's got one hand on the gait belt, and of course she's watching. She's watching his hips. You can tell a lot by just watching somebody's hips. You can quickly right them if they start to lose their balance just by correcting the hips. Because as they start to go, they start to wobble this way, or wobble the other way, or front and back. You can see it really quickly. You can react as a therapist really quickly to correct the problem and keep them from falling. So watching the hips, working from the hips, not grabbing onto the shoulders, kind of thing, pulling from the shoulders, the hands, really on those hips. The gait belt is kind of waist height. See why we cover your backside. That's what we talked about this, I think, in one of the labs and all the labs. It's good to always have a gait belt on the client, especially as a student. Some experienced therapists don't use gait belts for different reasons. But as a student, I would always recommend using a gait belt because if they fall, you have to do the incident report and they're asking you, did you have a gait belt on the patient? You want to be able to cover yourself and say, yes, I did. So always the gait belt. Spread of disease, another thing to keep in track with the gait belts. Some therapists like to put the gait belt on their hips and go from patient to patient, especially these days. Don't really want to do that because you're kind of carrying the disease from patient to patient, washing and wiping it down between clients, that sort of thing. Hands-free, wide, as a therapist, wide BOS is base of support. She should have a nice wide base of support. She's ready to grab him and do what she needs to keep him upright. Staying close. Got to stay close when we do our transfers. The thing that students have struggled with always is being too far away, being afraid to touch, to get into somebody's personal space. Really have to get over that pretty quickly because you have to keep that person safe. It's really your job to keep them safe. You don't want anybody to fall or come close to falling. So to do that, you have to stay close, watch their hips, that wide base of support, all those different things we're talking about. The biggest thing really is to stay close to your client. Body mechanics, protect yourself. It's very, very easy to get hurt doing transfers as a therapist. This is bad. She's bending her back. Looks awful. Here she's bending her knees, doing a nice squat. Really want to feel the work that you're doing in your quads. Feel it in your legs as you're pushing the person up and going with them. Don't want to feel it in your back. If you're feeling it in your back, you're doing the transfer wrong. You're not getting low enough. Some of you that are taller, like myself, to really squat and stick out your butt and get a wide base to do this right. We'll practice this in the lab. Let them do the work. We can't say that enough. Let them do the work. You're not here to do the transfer for them. Your job is to help them be independent. So your job really is to make them do all of the work or do as much work as they possibly can by keeping them safe because you want them to get stronger. You want them to be more independent. You don't want them to rely on you. You want them to get to the point where they don't need to rely on you and anybody else. They can do it safely. So let them do the work. Those of you who've worked at CNAs or aides or other professions around healthcare, you're kind of trained to jump in and help. We want to help. We want to help the person become independent and definitely keep them safe, but don't do too much. Have them work as much as possible. Be prepared, know the steps, where you want to go, everything prepared, working from the hips, we talked about that, and don't pull on their arms. Older folks are very, very vulnerable, shoulders and arms. You have poor leverage from the arms, poor control from the arms, and you can really hurt somebody pulling on their arms. Here's some examples of the sit to stand that you'll be doing with good and bad technique. In this one, it's bad. He's pulling from the arms. He's kind of curving his back, not bending his knees enough. He's working too hard. This patient is doing nothing. She's just along for the ride. We don't want our patients along for the ride. We want our patients working hard to get independent. She should be reaching back, and helping, that sort of thing. He should be down here around our hips with a gait belt, ideally. With this one, with the therapist, it's more the therapist guiding from the hips, the patient doing all the work. Therapist guiding, patient doing the work. You're going to see that more accurately in this picture. Just try this at home as you're watching this to get a sense of why we are preaching all these tips and positioning. Going sit to stand with armrests and without armrests can be a big difference. So we want our clients to use their arms always and push. Use your arms to push. Your arms are strong. You have one arm, whatever you have, I want you to use it and to push as hard as you can. Engage those deltoids and those triceps and the biceps to get yourself up. And then if you do a sit to stand, just try doing it from your way back in the chair and then sliding to the edge and coming forward. And there's a dramatic difference in terms of how much easier it is to transfer from the edge versus way back. Again, we want to facilitate independence, clients working, so have them slide to the edge before they stand up. And then there's a difference between your legs in and your legs out. You try it, your legs out, going sit to stand, and your legs in, coming sit to stand. You can see, again, a big difference in terms of leverage and push with your big, strong, and quad and gastroc muscles to go sit to stand. And then the weight shift. We said nose over toes. Why do we say that? Because we want that forward weight shift. We want them to shift their weight forward. If they're not doing nose over toes and they're staying in neutral or kicking back the other way, it's so much harder for them to transfer. When you stand up, start thinking, noticing this as you get up every time, as you go about your daily lives, you're always shifting your weight forward, even if it's just subtly. We need to have our clients do that. It's a big part of sit to stand is that forward weight shift. Here are the steps for the sit to stand. Transfer of the strong side. So this person, you can't really see the therapist, but let's say his left side is his strong side. We're not really transferring, we're just going up, but she's protecting his weak side here. Sliding to the edge, pushing arms, legs, we talked about that. Forward lean, nose over toes, flexing hips. He's got that forward lean, his nose is over his toes. Pushing up, he's pushing with his arms, he's helping out. Standing fully, before sitting, kind of down here, feel the wheelchair or chair on the back of your legs. Reach back, she's reaching back and sitting slowly. Emphasize sitting slowly. There's a lot of your clients you'll quickly see once you're out there love to plop because they're weak. They get to a certain point, things just give way. Plopping is not good because it doesn't take much, especially if they're coming down onto a hard toilet, to get compression fractures, awful compression fractures in their back. And it can happen that quickly, that easily. Don't want it to happen to you as a therapist. Always have them sit slowly, safely. Position yourself depending on the cyst level, work from their hips, belt, giving the client space. We'll really get into this in the lab. And then the stand pivot. So you're standing the person up, and then you're kind of moving them, in this case, to the mat and sitting down. So you go from sit to stand like we just did. The difference is you're kind of shuffling, moving, and then sitting. Wheelchair at 45-degree angle to toilet or whatever as you're going. So this is the 45-degree angle. Here's the chair. There's the mat. And this is kind of a general parameter. It really depends on the situation and what really works for a particular transfer. Transferring off the strong side. So what do we mean by that? His left leg, we'll say, is his strong leg. So he's transferring, pivoting off that left leg as he turns, pivots, and sets. This is kind of hard to talk about. Again, we'll do it in the lab. You'll get a sense of what I mean. Definitely locking the brakes before you get up, or locking the brakes of the chair that you're moving towards. Leaning forward, pushing with the arms. Standing up fully, all the way up with this one. Not halfway, but all the way up. Then you step, kind of pivot. Make sure you feel it, the mat on the back of your legs, and you're sitting. Okay, some upcoming things, the homework 7, and then the quiz, the lecture questions, these lecture questions, and then the SLD and all this stuff. Okay, let me know if you have questions.